Margaret Chen stands in the parking lot of her primary care clinic in Phoenix at 7:15 in the morning. The doors are locked. A handwritten sign taped to the glass reads, "No longer accepting traditional Medicare, effective immediately." She's been coming here for 12 years. She turns 65 next month. "I don't understand," she says to no one. Where am I supposed to go?" She's not alone. Across 23 states right now, tens of thousands of people are staring at identical signs, locked doors, disconnected phone lines, patient portals that no longer load. This isn't a provider shortage. This is systematic abandonment, and it's accelerating. I need you to do something right now. If you're about to turn 65 or you know someone who is, I want you to pull up your Medicare provider directory. Go ahead, look at the specialists you'll need. Now call 3 of them, ask if they're still accepting new traditional Medicare patients in 2026. I'll wait. I'm Helen Morland. This is the Morland Report. I spent 15 years as a healthcare policy analyst inside the system, CMS contractors, insurance working groups, reimbursement committees. I've seen the internal models. The mainstream media is calling this network adjustments. I call it what it is, a controlled demolition of Medicare access. And the people turning 65 this year are standing directly in the blast zone. Let me show you the numbers they're not putting on the evening news. Between January and March of 2026, 1,147 primary care practices across the United States have formally announced they will no longer accept traditional Medicare patients. That's not reducing their Medicare panel. That's complete withdrawal. In the same period, 412 specialist groups, cardiology, endocrinology, orthopedics, have implemented Medicare patient caps, which is code for we'll see our existing patients until they die, but we're not taking anyone new. Here's the key mechanism. Medicare reimbursement rates were effectively frozen in the 2025 budget reconciliation, frozen, but practice costs, rent, staff salaries, medical supplies, liability insurance, they went up an average of 8.3%. I obtained internal documents from a regional medical association in Ohio that modeled this out. Their conclusion, and I'm quoting directly, practices that maintain Medicare loads above 40% will operate at a net loss by Q3 2026. So they're doing exactly what the models predicted. They're cutting Medicare patients to survive. Now, CMS, the Centers for Medicare and Medicaid Services, will tell you that Medicare Advantage plans are the solution. They're pushing people toward private insurance companies, managing Medicare benefits, and on paper, it looks better. Medicare Advantage has higher reimbursement rates, so more doctors accept it. But here's what they're not telling you. Medicare Advantage plans operate on network restrictions, prior authorization requirements, and utilization controls that traditional Medicare never had. Let me introduce you to Robert Kaplan, age 66, retired electrician from outside Milwaukee. Robert enrolled in a Medicare Advantage plan in January because his doctor told him he had to. The practice was dropping traditional Medicare. In February, Robert started experiencing chest pain radiating down his left arm, classic cardiac symptoms. His cardiologist ordered a nuclear stress test. The Medicare Advantage plan denied it, required a standard treadmill test first. That got approved for 3 weeks out. Robert had a myocardial infarction in his driveway 9 days before the scheduled test. He survived. His ejection fraction is now 35%, permanent heart damage. The stress test he needed would have caught the blockage. The plan saved $200. Robert lost his heart function. This is the trade-off: access to a network versus access to care. And here's where it gets really disturbing. The people turning 65 in 2026, this specific cohort, they're arriving at the worst possible moment. They missed the window when traditional Medicare still had robust networks, and they're entering Medicare Advantage plans that are actively restricting access because they overexpanded in 2024 and 2025 and are now hemorrhaging money. I want you to look at this timeline with me. In 2023, Medicare Advantage enrollment grew by 2.7 million people. In 2024, it grew by another 3.1 million. Insurance companies were pouring money into advertising, offering $0 premium plans, dental and vision benefits, gym memberships. It looked incredible, but those plans were underpriced, actuarially unsustainable. The companies were buying market share, and they always planned to tighten restrictions once they hit enrollment targets. Well, they hit those targets, and now the restrictions are coming. Internal communications from three major Medicare Advantage insurers, documents that were leaked to healthcare policy researchers at Georgetown University in January show explicit strategies to increase prior authorization denials, narrow specialist networks, and reduce approvals for durable medical equipment. One memo uses the phrase defensive utilization management. That's corporate language for make it harder to use your benefits. The American Medical Association released survey data in February 2026. 94% of physicians reported that prior authorization requirements have increased in the past 12 months for Medicare Advantage patients. 94%. And the average time to get authorization for a specialty medication or advanced imaging, 14 days, 2 weeks. In 14 days, a cancer can metastasize, a clot can embolize, an infection can go septic. Let me take you to Florida. I've been tracking reports from patient advocates in Brevard County, Polk County, and Duval County. Here's what they're documenting. People turning 65 are enrolling in Medicare Advantage plans, receiving their insurance cards, and then discovering that the specialists they need, the oncologists, the neurologists, the orthopedic surgeons, aren't actually accepting new patients from their plan, even though the provider directory lists them as in network. The directories are outdated, sometimes by 6 months. CMS requires insurers to update directories quarterly, but there's no real enforcement mechanism. So people show up for appointments and get turned away. And here's the mechanism that makes this a crisis, not just an inconvenience: the Medicare enrollment windows. You can only change your Medicare plan during specific periods. If you enroll in a Medicare Advantage plan in January and realize in March that you can't access the care you need, you're locked in until the next annual enrollment period in October. 8 months. That's 8 months where you're paying premiums for access you don't have. Now, let me show you the cascading effect. When people can't access primary care, they go to urgent care. When urgent care can't handle their chronic conditions, they go to emergency departments. ER volumes in markets with high Medicare Advantage penetration are up 11% year over year for patients age 65 to 70. That data comes from the National Hospital Association's Q1 2026 tracking report. Emergency departments are the most expensive site of care in the entire system. And Medicare, both traditional and Advantage, pays for it. So we're spending more money, getting worse outcomes, and destroying continuity of care. Let me tell you about Linda Vasquez, age 65, former teacher, San Antonio. Linda has type 2 diabetes and hypertension. She had a primary care doctor she'd seen for 8 years. When she enrolled in Medicare in February, her doctor's office told her they were no longer in her Medicare Advantage network. She was assigned a new PCP, primary care physician. First available appointment, May. It's March. She's out of her blood pressure medication. She went to an urgent care clinic, and they refilled it for 30 days and told her to follow up with her PCP, but her PCP appointment isn't until May. So she's cycling through urgent care every month, seeing a different provider each time. No one managing her diabetes, no one adjusting her medications, no comprehensive care plan, and her plan is collecting premiums every month. This is what systemic failure looks like at the individual level, and it's being replicated in hundreds of thousands of lives right now. Now watch what happens when this continues. We're in March 2026. Let's project forward. By June, the people who enrolled in January and February will have been locked into inadequate plans for 6 months. They'll have burned through urgent care visits, delayed specialist appointments, and skipped preventive screenings because they couldn't get access. What happens to a diabetic who doesn't get regular A1C monitoring for 6 months? What happens to someone with atrial fibrillation who can't see their cardiologist to adjust their anticoagulation, complications, hospitalizations, preventable deterioration? By October, when the next annual enrollment period opens, these individuals will try to switch plans. But here's the trap. If you want to go back to traditional Medicare from Medicare Advantage, you can, but you might not be able to get supplemental insurance. Medigap plans in most states can deny you for pre-existing conditions if you didn't enroll during your initial enrollment period. So people are locked into Medicare Advantage, not by choice, but by insurance underwriting rules. And here's the geographic expansion. This started in Sunbelt states, Florida, Arizona, Texas, because those are high growth Medicare markets, but it's moving north and east. I'm receiving reports from advocates in Pennsylvania, Michigan, Ohio, same pattern: provider withdrawals, network restrictions, access delays. Have you noticed that your local hospital has started advertising its senior ER or Medicare Fast Track? That's not a service improvement. That's a response to volume surge. Hospitals are creating dedicated units because they know what's coming. Let me ask you, what happens when rural providers start dropping Medicare? We're already seeing it in Nebraska, Montana, Eastern Oregon, in counties where there are 2 primary care practices total. If one of them stops taking traditional Medicare and the other one is full, what do? You drive 90 miles, 2 hours to see a doctor. And here's the vulnerable population impact. People aging into Medicare in 2026 are not a monolith. Some of them are healthy, wealthy, and capable of navigating this, but many are not. Low-income seniors who qualify for Medicare and Medicaid dual eligibles, they get automatically enrolled in Medicare Advantage plans in many states. They don't choose it. The state chooses for them, and they have the least capacity to advocate for themselves, appeal denials, or find alternative providers. We are creating a 2-tiered system. If you have resources, education, and health literacy, you'll find workarounds, you'll pay out of pocket, you'll travel, you'll fight. If you don't, you'll fall through. This isn't a hypothetical. I'm watching it happen in real time. Here's what you must do right now. If you're turning 65 this year, do not enroll in a Medicare plan based on premium cost or benefits brochures alone. Call the providers you need, your current doctors, the specialists you might need, and confirm they accept the specific plan you're considering. Not just Medicare Advantage, the specific plan. Get it in writing. If you're already enrolled and you're experiencing access problems, document everything, every denied authorization, every delayed appointment, every time a provider directory is wrong. File complaints with your state health insurance assistance program and with CMS. Individual complaints don't always trigger action, but patterns do. Stock your medication. If you have a 90-day refill option, use it. If you can't get in to see your doctor, at least you have your meds. Know your backup options. Which urgent care clinics are near you? Which hospitals have your records? If you can't access your PCP, where will you go? And if you're outside the Medicare age range, don't think this doesn't affect you. This is a preview. The mechanisms being built into Medicare Advantage right now, the prior authorization algorithms, the network narrowing, the utilization controls, their beta tests for the entire insurance market. What's happening to 65-year-olds today is coming for everyone tomorrow. Tell me what you're seeing. Comment below with your city and state. Are your providers dropping Medicare? Are you facing access delays? Are the directories accurate? We're documenting this in real time. This is the ground truth. This is the data they're not collecting. Subscribe right now. Share this video with anyone turning 65, anyone on Medicare, anyone who thinks this doesn't matter. History is being written. The safety net is tearing, and we're the ones who have to document it. I'm Helen Morland, and this is the Morland Report.